Thanks so much, Clay. I really appreciate it. I want to thank the organizers, thank all of you for asking me to speak and attending today. So in my 20 minutes, I'd like to review a little bit of the what's going on with coronavirus, talk about some of the cardiac manifestations, how it affects the heart vascular tree, and then what I'd really like to do is spend a little time on the medications for heart failure and some of the controversy on ACE inhibitors, ARBs, and try to reassure you that you're doing all the right things, taking your medications. And if we have some time, I'm happy to chit-chat a little bit about return to athletic competition for the athletes that are out there. It's a topic that Clay and I share with sports medicine, and there's some real controversy going on with that right now with our Philadelphia Eagles and college teams. So yeah, I'm with Cardiology Consultants of Philadelphia, and I've been there 4 years. And next slide, please. My favorite organ to the left, the heart, and my least favorite virus to the right, the coronavirus. I think you've seen so many pictures of this virus. It really is just all over the place. Next slide, please. The coronaviruses are not new, and they are part of the common cold. And large family of viruses, it is really based on how bad they are. Do they cause disease? And the big three that we really talk about are SARS-CoV-1, SARS-CoV-2, what we're living right now, in MERS. They did come from cross species, not to spend a lot of time on it, through bats. Originally and still to this day, really droplet transmission is the primary mode. Coughing, sneezing, something getting into your eyes, mucous membranes. But there's growing evidence that just speaking to people within just a couple feet can transmit the virus at a high rate. Next slide, please. Thanks so much. Well, we hear COVID and you hear SARS-CoV-2. The disease process is COVID-19. The disease is caused by the virus, SARS-CoV-2. Primarily, you know that it does affect the lung. That's what we've really seen, but it's systemic. And we'll talk about the virus, how it gets into cells, why it affects cells. But suffice it to say, it actually, those spikes you see on the top of the cells, they bind to a specific ACE2, angiotensin converting enzyme receptor, which is very important to heart, vascular, lung, kidney, and GI tract. It's very important for the heart patient to understand that this receptor is an inverse regulator to the renin-angiotensin system, which we fight so hard against. And that's something that causes increased work of the heart, fibrosis. And that's why the ACE2 receptor is very, very important. And we'll touch a little bit about the medications and try to reassure you that staying on your medications, being plugged in with your cardiologist, your healthcare provider is so important. Next slide, please. Cardiac involvement is common. And we do know that cardiac risk factors in patients with heart disease or stroke are at heightened vulnerability. Not only are they more vulnerable, but when they have the disease, they tend to have worse outcomes. Looking from the Chinese data, just looking at the cardiovascular prevalence of about 16%. If you go down to the last kind of take-home message, the overall mortality for all comers was about 2%. However, if you had heart disease, your mortality was almost 11%. If you have these other risk factors, hypertension, diabetes, you can see why it's such a big concern of the heart community that patients with heart disease take it seriously and are protected. Next slide, please. Recent finding, which right now is all over the internet and social media, kind of looking at what's happening to the heart long term. This just came out online just a few weeks ago and is very concerning to us. So these were 100 patients, 2/3 were at home. They all recovered. These are all comers. There was a cardiac MRI that was performed 71 days, and they found 78 of 100 patients had structural changes, whether it's a drop in ejection fraction, scar tissue, increased volume, and 60 of the 100 still had ongoing inflammation almost 3 months after the recovery. Additional kind of early data looking at autopsy found that they were able to find the virus in a high proportion of patients very early in the disease. Next slide, please. Well, how does COVID-19 or SARS-CoV-2 affect the heart? Well, there's direct and indirect. And if you watch the news today, they're talking about football players going back, high school, college, professional, soccer players, lacrosse players, about this myocarditis and the question. And we do see myocarditis in athletes. And a statistic today, about 8% of sudden events in athletes is related to myocarditis. And there's direct infiltration of mononuclear cells into the heart muscle itself, into the lining of the arteries. So that's the direct effect of the virus coming into the muscle, affecting the arteries and veins, and the kidney and the brain and the heart and the lung. But there's indirect effects of SARS-CoV-2, part of an inflammatory response that the body starts to really hurt itself. And that's what you've heard about, the cytokine storm and the surge. Next slide, please. Well, the endothelial damage really starts by this virus coming in through this ACE2 pathway, and it directly injures the heart, the arteries, the GI tract. It has a great affinity for the kidney. And for our heart failure patients, what we're concerned, not only is it going to trigger acute on chronic heart failure, but it also may cause new cardiomyopathies, new drop in ejection fraction. When I did these slides several weeks ago, they were talking about 1/3. I've seen numbers as high as 50% now that may develop at least transient cardiomyopathy. And the key is that the presence or absence of a new cardiomyopathy is really, and the degree of how the heart muscle and vascular tree is involved in COVID-19 is crucial to the management and the outcome of the patient. Next slide, please. Kind of a little depiction of myocarditis. They were talking today, myocarditis in athletes account for about 9% of sudden events. This is a boggy, inflammatory heart that just stops working, and fluid builds up in the lungs. You can't push blood to the kidneys, to the brain. It's just a bad actor. Next slide, please. This is an electron micrograph actually depicting the virus in heart muscle. So this virus is not a good actor. Next slide, please. Well, the other indirect effects that I want to mention about how it can affect the heart muscle is by affecting the lung, you affect the right heart. By affecting the kidney, you affect fluid. By affecting the GI tract and nutrition, all of these things increase the workload of the heart. And you may have heard of this supply-demand mismatch for the heart. And the heart, not only is it can't provide blood flow and oxygen and food, nutrition to the rest of the body, it really can't sustain itself. Next slide, please. Some of the other indirect effects that you may have read about is that what does the inflammation, what does it do to blockages in the arteries? What does the surge that our body now is trying to protect itself with, catecholamines, our stress hormones, things you may have heard about, interleukins in the past, that it just increases the irritability in blockages in the arteries. It can cause stress cardiomyopathy, where the heart muscle will acutely stop working, not due to a blockage in the artery. And the other, and bleeding at the same time. And they recognized early that there were younger people without other risk factors who were presented with large vessel stroke as the first presentation of SARS-CoV-2. Next slide, please.
I am having a message that my internet connection is unstable, so hopefully I'm not gonna lose you all here.
Other indirect effects that are specific to our heart patients have to do with electrolytes and arrhythmias. And again, because of the way this virus comes into the cell and how it affects the renin-angiotensin system, there's a big issue with low potassium, changes in calcium and magnesium that make the heart very irritable, not only for irregular heartbeats from the upper chamber, but also from arrhythmias from the lower chamber. And in the critical care literature, about half the patients who are admitted to the ICU will have a serious life-threatening cardiac arrhythmia. Next slide, please. What treatments do we have? Well, we all know about viruses, antivirals that we can use that can shorten the time period. We most certainly know about steroids and dexamethasone in that late stage of the cytokine storm. But right now, there is no approved treatment that either is going to prevent or treat. And we do not have a vaccine. So the decision for how do we treat patients really is what does a patient look like? What are their vital signs? What are their laboratory? And what is their pre-existing risk? And this is really a very clinical. Folks that are hypoxic, short of breath, increased fluid uptake, reduction in functional capacity, neurologic symptoms, those patients, the safest place for them is to be evaluated in the hospital. So I urge our heart patients really to listen to their body, report symptoms, and have a low threshold to seeking medical attention. Next slide, please. I want to talk a little bit about ACE inhibitors, ARBs, angiotensin receptor blockers, and renin-angiotensin system, because early on in January, there were these statements that came out that were flagging heart patients and blood pressure patients and diabetic patients who are on ACE inhibitors, captopril, enalapril, ACE inhibitors like ARBs like valsartan, and even Entresto, the ARNIs, that there was a theoretical risk by taking these medications that you would increase the ACE2 receptor activity and increase the likelihood that the virus would come into the cell. And the answer is, looking at these statements that came out starting in March from combined statements from the American Heart Association, American College of Cardiology, and European Society of Cardiology, is that the data did not support that. Recent studies from JAMA have looked at folks on ACE inhibitors and ARBs, that they were now more likely to have COVID, and nor did they have worse outcomes. There was a nice for our TAVR patients out there using ramipril, basically looking at the positive remodeling effects after TAVR, transcutaneous aortic valve. And those patients, when they looked at their data, there was no impact in the post-TAVR patients who were on ramipril to having either increasing COVID or worse outcomes. The article that I really enjoyed reading is from June 23rd. And this really looked at the interaction of SARS with our angiotensin system and why our patients protected. And it does look like, if you look at some of the clinical research in circulation, that there is a protective mechanism. And not to bore you with all the pharmacology and biochemistry, but when we block the A2 receptor, and we were blocking that either with angiotensin receptor blockers, or we're going to increase that activity when we use ACE inhibitors, which actually block the transformation of angiotensin 1 to angiotensin 2, which then blocks to this A1 receptor, AT1 receptor. It modulates with the ACE2 receptor, and it triggers a very positive cascade of vasodilatation and anti-inflammation. And one of the postulated mechanisms is that by being on those medications that would include Entresto, that you actually increase the competitive binding of SARS-CoV-2 to this ACE2 receptor, therefore giving protection. So what I wanted to make sure that I could drive home is that in our heart patients on these medications, please do not stop them without talking with your heart doctor, cardiologist, because there's growing data that the medications that you are on have protective effects, okay? So do we have 2 minutes? We're at 2:21. If I could just make one other statement on return to play in athletes. And the reason why I say that is that over the last 2 days, we have Power 5 conferences for football going in different directions, Big Ten, and Pac-12 versus the Big 12. So my feeling and looking at what the cardiology literature has shown is that if you are an athlete, high school, collegiate, and you are asymptomatic, but you test positive, they recommend 2 weeks of no athletic activity from the date that you test positive, and that you should be individualized. No symptoms to positive test, individualized. How do you go back to athletics? And this goes down to high school kids. If you had symptoms, any symptoms, mild, moderate, or severe, then they're recommending several things. One, there's no athletics for 2 weeks. Number two, that you consider obtaining a troponin blood test looking for a release of one of our contractile proteins. Next would be a screening EKG. And then lastly would be a 2D echocardiogram. And if those are negative in a patient who had symptoms, then they can return to athletics. Those folks that have either an abnormal study, or if you were hospitalized and you had findings of a new cardiomyopathy. And this is what is very concerning, is that you can also be asymptomatic and still have a cardiomyopathy. And we saw that just recently with one professional football player, professional lacrosse player, that were screened and they actually were found to have a new cardiomyopathy. Those folks are treated as, just like all cardiomyopathies, that they're out of athletics for at least 3 to 6 months. They have cardiac MRIs to guide what's going on. And until they have full resolution of their cardiomyopathy, they are not allowed to participate in high intensity athletics. So these are interesting times as we try to get high schoolers back to intensive athletics, college and professional. But this also applies to our heart patients who do participate in higher impact athletics. And we do have folks, whether they've had heart surgery for coronary disease, valvular heart disease, or arrhythmias. So it's just another kind of take-home message I wanted to let people know, that there's a lot of information. It's very much in flux. We don't have a very good understanding on high schoolers and young adults yet on how we should be risk stratifying these folks. So it's a very important topic to myself. I have 2 children that play college athletics, and very challenging times to figure out what to do for these students, these student athletes. But it's also, I think, a very good take-home message for our heart failure patients that are going to go on to do intensive athletics, intensive training, and we encourage that. So that's, I did keep it to 22 minutes.
You did great. You have plenty of time for questions.
A lot of information, take-home message, take your heart medications. I'll put a plug in for statins. Clearly there's some anti-inflammatory protection in statin therapy that may be beneficial for cardiomyopathy. Vasodilating beta blockers that have antioxidant and anti-inflammatory properties may be beneficial. So although our heart patients are more vulnerable, some of the medications that have been proven throughout the years to improve quality of life and life expectancy also tend to have a very positive effect on SARS-CoV-2. So I encourage everybody to stick with their medications. Please follow guidelines. Do not get sick. Wear a mask, socially distance, and then get through this.
Rebecca, I have a question if no one else has a question.
Go ahead.
So, Chris, this is a very poignant time, exactly like you said. So I received a request from a friend of mine whose daughter will be a rising senior at a university out in the Midwest, and she's a Division I lacrosse player. And she was at the Jersey Shore, and she attended a party, and she came home. Several days later, had a sore throat. She got tested, and she was positive. One of her parents got sick, and one of her parents turned positive as well, but had no illness. She's going back to her university next week. Now, her fall season has been suspended for Division I lacrosse, the fall. But the question to me was, what is going to be for if they do have any type of fall workouts, or if they intend to have a full season in the spring of 2021. and she was symptomatic only with a sore throat, self-limited illness for 3 days, should they get any further workup other than her routine physical exam when she returns to the university?
My feeling is that they do need to be seen by a cardiologist. I think the minimum is an EKG and a physical examination. If they're out of the index, if everything is normal, normal EKG, normal exam, and they are going to be supervised, and they do have athletic trainers. Each individual university may have different guidelines, but I would say the minimum that you would require is a visit with the cardiologist and an EKG, and that would have a very low threshold to do an echo. So I just think, the data is still evolving. These are the current guidelines for May. So even if you are mildly symptomatic, they are recommending that you go to a healthcare provider, you consider a troponin, an EKG, and an echo. And if you flunk any of those things, you need additional cardiac imaging. If your cardiac MRI is even mildly abnormal, then you are done for 3 months. So that's what I am going to recommend, is that they have to be seen EKG and then individualized based on what you see and what they're doing.